And if you guys remember that slide where I talked about the intrinsic factors of development of GERD, the mucosal lining of the stomach has the ability to not be broken down by acid. What happens in Barrett's esophagus is the lining of the esophagus changes to match the lining of the stomach and the small intestine so that it doesn't get burnt by GERD. That sounds fantastic, right? You've just fixed GERD on your own. But that condition where that changes is the first step in the development of cancer. So patients with Barrett's have a higher risk of developing cancer because they've already broken down one of the protective barriers, which is you get pain, you treat it with reduction of acid. And then another complication is obviously the progression of Barrett's to an adenocarcinoma or cancer of the esophagus. Some of the atypical features of heartburn, just to kind of touch on them, include chest pain. Sometimes patients even go to the ER thinking, oh my gosh, I've had a heart attack. They get a complete cardiac workup. Lo and behold, it's terrible heartburn. The cough, asthma, and laryngitis that I mentioned as well earlier could be atypical symptoms of it. And the typical are those heartburn, pain right here type sensations. Okay, medical management of GERD. So the most important thing from my end of treating GERD is lifestyle modification. Diet is very important, and I won't just say diet. I like to group the first two together, diet and weight loss. Diet is important because we have certain foods that elicit the sensation and symptoms of heartburn, and also the timing of when we eat. Late meals, large size meals, those perpetuate heartburn as well. Weight loss is super important in the management of GERD. As you increase your abdominal girth, the pressure of your abdomen increases and the pressure of your chest decreases, and you get a pressure barrier that breaks down that sphincter compensatory mechanism and lets food come up, thus developing heartburn. So when you lose weight, you've kind of neutralized those pressures. It's physics there. And you won't have as much buildup of the food coming up, therefore reducing the GERD. Important also is to tell my patients no late night eating, no snacking, no eating after 7, no eating and then going to bed immediately afterwards. If you do have to go to bed or you are going to sit back and relax and watch the Clemson Tigers play, you got to make sure that you're sitting upright on pillows, keeping your head up and your feet down. In an upright position. That's just to have gravity help sort things out. It's hard for things to move up fighting against gravity. Some patients even have to sleep upright in chairs. You can see here the guy saying the pillows are multiplying. I'm going to go ahead and assume just looking at him, he probably has a lot of GERD. And he's got a lot of pillows there to keep him propped up at night because of those symptoms. So keeping your head upright should you lay down within close proximity to a meal within 1 to 2 hours is important to prevent the GERD from happening. Types of medications we use. I think we're all familiar with the plop, plop, fizz, fizz, what a relief it is of antacids. Antacids are great neutralizing buffers of the stomach. I used to watch my grandfather eat baking soda like it was going out of style. Why? Because it neutralizes the acid of the stomach. We now have, Alka-Seltzer and those type of things, Gaviscon, and those medicines now that are available over the counter that help neutralize acid that are great for symptom relief. Meaning, if you've already developed heartburn and you're looking for relief, they're fantastic to grab to help take care of that. These H2 blockers, ranitidine, cimetidine, also known as Zantac, Pepcid, those are a type of medication that help reduce the body's ability to release as much acid. They work via the histamine channel, which is a very complicated channel that you see over here, but when you block histamine, you block these cells, the parietal cells, from releasing as much acid. The latest and greatest probably medication of the 20th century was the development of proton pump inhibitors. And you guys are probably thinking, what is a proton pump? Proton just means the acid. They're acid pump reducing medicines. A proton is a positively charged ion here, H plus being the acid is a proton. So they block the release of that, blocking the release of acid from the stomach. the development of PPIs dramatically revolutionized how we manage heartburn and GERD and took care of a lot of people with peptic ulcer disease and ulcer development in the stomach. These medications work for a lot of people, but not for all. In fact, refractory GERD can occur in 10 to 40% of people, and these people fail to respond to the medications. At that point, that's when you start to say, is there a need for some type of anti-reflux surgery to be done to fix whatever has caused the breakdown of that barrier? This is a study quoting the usage of these PPIs, again, kind of going into those refractory patients. But people who were on PPIs still complained of all these symptoms listed here. So they're not perfect in their working, but they do work for some. And a lot of people have severe chronic reflux, and again, they don't get the full response. The other thing is that they don't necessarily fix whatever breakdown has occurred at the lower esophageal sphincter. Thus, PPIs prevent acid from being released, thus treating your symptoms, but they don't fix the problem of an incompetent sphincter. Some patients can just live their whole lives taking those PPIs, but others need to have repair of this to get symptomatic relief of their reflux. There are a few risks associated with long-term PPI use. PPIs, just to name some names, not that I have any special endorsements by any of these, but Nexium, Pantoprazole, Dexilant, those are a few names of those, just to familiarize yourself with them. Omeprazole, Pantoprazole would be those. There has been a plausible risk of osteoporosis development. This has not been proven. It is not found to be causable. However, the reduction of acid interferes with calcium absorption. Thus, the FDA said that's enough for us to make the PPIs put a warning on there that you could develop bone loss with this. Also, PPIs do induce osteoclastic activity. Osteoclasts are the cells that break down bones. And with those two properties being enhanced, the FDA said, let's go ahead and put the warning on this so people are aware while we do the studies to see if it truly does interfere or to cause the development of osteoporosis. So far, they have not found that it causes the development of osteoporosis, but certainly in patients that are at risk for developing that or have calcium or electrolyte abnormalities, we do take that into consideration and say maybe you shouldn't be on one of these medicines for a very long time. The development of gastric polyps is physiologic with the use of an antacid, meaning you're blocking the ability for acid to be released, so acid kind of builds up and forms these polyp-like things. The good news is they are not precancerous polyps. The bad news is they can cause things like obstruction and they can bleed and things like that. So it does predispose to the development of those. Not every patient on PPI does develop those, but they can. There are drug-to-drug interaction issues. The way that you take your PPI for most of them is 30 minutes before a meal on an empty stomach, then you can eat. If you were to just wake up in the morning and take all your pills, there's a chance that the PPI could prevent the activation of whatever other meds you're on in the stomach. Hence, we tell you to take it 30 minutes before a meal and before your other medicines. But they certainly can compete with absorption. Other adverse events from PPIs, I would assume this is referring to the possibility of some electrolyte abnormalities due to the way that the PPI reduces the acid, and it can interfere with that. Some patients don't want to be on drugs for their whole life, which I can completely understand. Some people have a phenomenon called non-erosive reflux disease, meaning acid actually isn't coming up there, they just get the sensation that acid is there. That's a whole different bag of worms. And then the cost of them, they're not cheap. Insurances are starting to cover less and less. And these are medicines that some people have to be on for a long time. So if you can do a one and done, fix the issue, you've theoretically reduced the expense and the burden of GERD over the lifetime of the patient. Indications for surgery include esophagitis. I will point out from my end, and Dr. Montenegro can elaborate on this further, patients who do not respond to PPIs at all, meaning you get placed on an acid-reducing medicine for your GERD and you have no improvement whatsoever, are perhaps not the best candidates to have the reflux surgery, at least from the medicine aspect of it. Again, I'll let Dr. Montenegro discuss that. The persistence of symptoms despite medicine, that's what we just talked about. The presence of Barrett's esophagus. This, from the medical standpoint, is rather controversial. I won't elaborate too much on this, but from the most current literature, people with Barrett's esophagus should have eradication of the Barrett's before getting any type of reflux surgery. However, Dr. Montenegro can touch on that further because I believe the surgery literature varies a little bit from the medicine literature. And then non-acid symptoms of reflux, your asthma, chronic cough, laryngitis. If you suffer from those, surgery is a great way to alleviate that. PPIs help some, but this will get rid of it entirely. The tests you need before surgeries, I think this is probably a good place for me to stop. Dr. Montenegro, do you want me to go over this slide, or do you? Okay. So the tests you'll need before having the surgery would be an upper GI endoscopy. Dr. Montenegro or myself can take care of that. And that's where we take a camera and go down and look into your esophagus, your stomach, and your small intestine where it connects. That would let us see if there's any damage to your esophagus, let us check out and make sure there's no other causes of the symptoms you're experiencing. A barium swallow is important to have to make sure there's no structure abnormalities that aren't always visible on direct endoscopy. Things like rings or strictures would perhaps interfere some with the surgery. pH monitoring is and manometry are fancy tests where they actually take a catheter, a long, thin probe, and have you insert the catheter through your nose into your esophagus and stomach, and it measures how much acid comes up into your esophagus, and it also makes sure that your esophagus contracts correctly. You don't want to do any manipulation to the esophagus if you have a contractility disorder where your esophagus doesn't work right and food doesn't appropriately go down. When you have trouble swallowing because of that type of issue, surgery can only complicate that.